Tonight, we have the privilege of hearing from Dr. Ann Kenny, who is the professor of emerita of medicine and is she's board certified in geriatric medicine and in palliative and hospice care. Ann has been Ann, as she likes to be referred to, Ann has been a practicing physician for over 35 years, and she is recognized by her peers as top doc in geriatric medicine. Dr. Kenny has worked clinically as a geriatrician in nursing homes, assisted living, rehabilitation, and clinical outpatient settings. And Dr. Kenny has found joy in her work with individuals and their families managing issues related to the diagnosis of dementia. Her experience in partnering in the care of these families touched close to home when her own mother was diagnosed with dementia. Dr. Kenny joined with her mother and her brothers and her sisters to provide the best care for her mom during the early and middle stages following her mom's diagnosis. Her expertise, coupled with her mother's playful spirit and her siblings' openness, support, intelligence, and compassion, allowed for the highest functioning and independence of her mother for several years. As a result of that personal experience and her professional experience, she's authored Making Tough Decisions about end-of-life care in dementia, which is published by Johns Hopkins University Press. That came out in 2018, and it outlines care, emotions, and communication issues at the end of life in dementia. Her second book is co-authored with Teresa Webb, who is a nurse and is living with frontotemporal degeneration. It's called Your True North, a guided journal for those living with cognitive loss or dementia and legacy, love, and wishes for the end of life well lived. And it offers a guide for persons experiencing cognitive loss to begin to explore their own thoughts and wishes about their life and to prepare for the changes that dementia will bring. We are very excited to have Dr. Kenny with us this evening, and I am now going to turn it over to Ann to share with us Navigating Transition, Session 1.
Thank you for a very sweet introduction. I really appreciate it. As Stephanie said, I am a physician. I was a caregiver for my mother. And what I'd like to say as we go into this transitions talk is that when my mom transitioned from moderate stages to late stages of dementia, and we needed to shift to her end of life care, I did find that the healthcare system wasn't ready to shift with us. And so that is part of the reason I wrote the book, Making Tough Decisions about End of Life Care, but also why I'm very passionate about having discussions much as this one, because I think you need to take control of those decisions if you want to have a say in them, because still in 2024, it feels as if the healthcare system is still focused on healthcare and not on the whole person, not on the person-centered approach. And so tonight, I would like to talk quite a bit about that. And I think it's because I think, and this is part of the book, that death isn't just about health and medicine, but that spirit, mind, and body, and that we need to take back some of that complexity about how we want to choose to live. And then that will help us on and how we make decisions for how we'd like to change. So when I think about making this discussion go forward, I'm going to tell you when we're about to shift with the transition slide. First, I think when we're talking about getting a diagnosis of dementia, we need to be at the place where we get a diagnosis and we build knowledge and support. So the common scenario, I feel, and many people living with dementia that we've heard from in the many programs that CaringKind does and in different literature that I've read, is that people, when they're first diagnosed, are told something like, there's not much we can do, take this pill, take this medication, come back, kind of on a medical schedule, or put your affairs in order. But that is not the care that people actually want or need. What we find is that when people are given support and hope, that initial distress that often comes out at the time of a new diagnosis, whether it's a serious other serious illnesses like cancer, or the serious diagnosis of something like you have some cognitive changes, cognitive loss, dementia, is that people will go into a period of distress. And that distress will actually, in time, increase to a higher level of distress if they're not given some support and hope. But if given support and hope, it has been shown that that distress will markedly decline to a much lower level, about 5%, from a level of about 30% down to 5%. And so when people are looking for some kind of support, they aren't just looking for medical advice. They're looking for a more holistic approach. So a better way, or another way, is to have it be person-centered care. And in person-centered care, we're talking about when decisions are driven by the person's goals of care and wishes, where you provide support to that individual to express those wishes, where you provide support to families and caregivers so that the person may realize those goals and wishes, and help them navigate and coordinate that complex and confusing either healthcare system, diagnosis, and so that they can actually develop a plan of care. The Institute of Medicine defines patient-centered care as providing care that is respectful of and responsive to an individual patient preferences, needs, and values, ensuring that that patient's values guide all clinical decisions. So this approach is actually a true partnership between the person living with the diagnosis, in this case, dementia, and the healthcare system, their families and friends. What we want is people to start looking at the full patient, the full person. I say patient a lot, and I don't mean any disrespect to anyone. I'm a doc, so I do that. But when I say patient, I do mean person. But we want an individual approach, and we want it to be comprehensive. So when I look at this slide, I see that the healthcare system is actually fairly small, that the care plan is even smaller, but the person very large with a huge support around them. And so how do we operationalize this? How do we have interventions? And so in this, um, I've given some examples of what I think would be useful. For meaningful relationships, hopes and dreams, and daily activities, that's where family, friends, and peers come in, having these deeper discussions and having engagement that matters to that individual. In community support, that's where I see CaringKind coming in with its programming for early diagnosis or family caregiver support, or the myriad of other things that Stephanie started to discuss, and we know that they offer. For life skills, that it can be a referral to an occupational or speech therapist or a dementia specialist, like someone from CaringKind. And then for the other piece, for the physical health and the mental health, that's where the individual or whoever is on their team helps with lifestyle modifications. We know that in dementia, that exercise and diet modifications can markedly change the trajectory of the disease, prolonging people in the early stages. Sometimes medications can be involved as well, but other engagement and paying attention to mental health through meditation, journaling, potentially referral to a therapist, practicing gratitude, getting involved in the arts. There's so many ways to have a holistic plan that will actually enhance the individual's life, potentially slow the disease, potentially make day to day much better. And part of that would be discussing what comes next. It's happening again. Let's see if I can do it here. Oh, so then in the next stage, I'm learning. I'll get this maybe by the third talk. In the next stage, once we understand that we need a more holistic approach, the next thing to understand is what is the disease trajectory. And we know that, and in this slide, we see stages of Alzheimer's disease. It can be other dementias as well, but there's a period where there's preclinical disease, where we live we don't have any symptoms or signs, but most likely the changes in our brains are occurring, to the point where you start to potentially notice things, or your family members may, that there might be some mild cognitive impairment, moving on to the milder stages of dementia, then on to moderate stages, and then severe stages. What we know right now, as of 2024, is that this trajectory takes somewhere between 8 and 12 years on average. It can be shorter and it can be much longer. We are looking at people who are doing very well. I call them the exemplars. These are the outliers that I think are teaching us how we may be able to prolong our time in the early stages or the preclinical stages, so that the time that we live with this chronic disease um, remains mostly in the earliest stages of the disease. As of 2024, it is still a terminal disease, and hopefully in my lifetime, we will find a cure. But until then, we need to know that this is a very chronic yet terminal disease. And because it's terminal, it is important. And the reason we're having this discussion tonight is to actually address some of the things that, so we understand when it starts to move to the late stages, so that those decisions can be made about what to do in those late stages. And besides understanding the disease trajectory, we need to build knowledge about understanding the basics. And here I'm going to give a shout back out to Stephanie Shivers. She did an excellent talk on You've Been Diagnosed, What's Next? And if you are somebody living with cognitive loss, or you're supporting somebody living with cognitive loss, I highly recommend this talk to you. It the video helps people see how important peer support can be, how understanding where you are in the disease is, how you lean into your strengths, how you shore up some of your weaknesses, and that you'll be continuously adapting, and that you again, you want to play to your strengths. I can't recommend it to you enough. I think if you watch something like this, you'll get some of the basics of Alzheimer's disease and other cognitive loss, and you will see how many people are doing well living with dementia for a very long period of time. And it will give you that support and that hope that you're looking for. And once you've kind of gotten a feel for the lay of the land, and you've adapted a bit to understanding the new diagnosis and seeing what's potentially possible, then it's time to start thinking about what goals are and how you're going to communicate those goals, and how you can start exploring some choices for the later transitions. And to do that, I would highly recommend using the Conversation Project's What Matters to Me workbook. This is available at the conversationproject.org, as you can see on this slide. And it is a workbook that is written by people who are used to talking about serious illness. It's a workbook for people living with a serious illness. And what it does is it is designed to help you get ready to talk to your healthcare provider or your family or other people about what your wishes are. And it's not just about making medical decisions. This is about thinking about what matters to you most. I think that's the way we need to start most of our conversations. What matters to you? And then you want to share your goals and preferences with your healthcare team. And again, to start that dialogue, that rich, deep dialogue that's not just about the medical aspects, but about the whole person. If you're living with cognitive loss, again, I would highly recommend going through this. When you do um, don't think you have to sit and do this whole workbook at once. This is something to be taken time with, to contemplate, to go out for a walk, to go have tea, to talk to friends and maybe try some things out. Stephanie and I talk about being verbal processors. Sometimes you have to talk before you're going to write it down. You don't need to complete this in one sitting. You can skip questions and come back to them. You can skip them and not come back to them. But the goal of the workbook is to get you prepared to answer some questions. If you're a care partner, if you're somebody who's supporting somebody living with dementia, it's probably if you should use this workbook, it's important to help them explain to them why you want to use it. Saying things like, I want to make sure we know what's most important for you so we can have useful conversations with your healthcare providers. Again, take it in small pieces. Don't gang up and say we have to answer these. Skip questions. If you see somebody getting stressed out while you're doing it, time to take a break. But this is created by people who are used to talking about serious illness. And I think most of us are not used to talking about serious illness. So it's nice when an expert, much like you would go to a spiritual counselor or you would go to a therapist around different things, these people are used to talking in this language, and it it's a helpful approach, and I think it's done expertly. After we start to think about that, about like what you would want, I'm going to start recommending that we build support. And support is, I mean, it can be friends and family, but I want you to consider, from a medical standpoint, I want you to consider building palliative care approach into your support. Um, I will describe palliative care more in just a minute, but on this slide, what I want you to realize is that the push in palliative care is for some tangible benefits, and those are in your quality of life, in symptom burden, and in support for families. I think those three things come from palliative care that may not come from the other medical approach. Symptom support would be focusing on alleviating symptoms such as pain, shortness of breath, fatigue, nausea, depression. Depression is commonly associated with getting a diagnosis or being a care partner because of grief, which we'll talk about in the third talk. So that is a focus in palliative care. Um, Symptom quality of life also, to make sure that all decisions are being made from the person-centered values rather than from just this is what we always do at this point. It's very individualized. And 93% of people who have used palliative care recommend it to others because they find that it actually helps in the journey. So what is palliative care? It is a specialized medical approach that focuses on providing relief from symptoms and stress associated with serious illness. It isn't just about treating the illness itself, but about improving overall quality of life for both the person and their family. It's about comforting, not necessarily curing. It aims to bring a holistic approach to the patient's well-being, addressing not just the physical symptoms, but also the emotional, the social, and the spiritual needs. And again, looking at trying to take care of the whole person. And it involves a full team of various healthcare providers working together to offer that comprehensive support. It can include pain management, it can include counseling, spiritual support, and helping people with decision making. In this slide, I try to look at it a little more graphically. As you can see on the left-hand side, there's when you first get a diagnosis of your disease, you may be focusing on cures or controlling the disease. Um, and as you go through the disease, and honestly, pain and symptom management should be part of this, but often is not. But as you can see with a palliative approach, it is always in the center. And then as you move through the disease, you're going to be moving away maybe from curing and controlling more to rehabbing, focusing on that quality of life, whether it's as a survivor or as you move towards death and bereavement. But um, it again, the focus is what I like to call the right care at the right time. Early in the disease, the care may be more aggressive. The right care will then change as one works their way through a disease process until the end. And and so in this next slide, while it is a slide that focuses on healthcare utilization, the reason I bring it up is because when we use palliative approaches, it really reduces things like hospital admissions and emergency room visits. I've circled the outpatient because that's where most of us come from, but it decreases hospitalizations in all venues, whether it's inpatient, outpatient, or skilled nursing. And why is that important? When I first approached my siblings with this, that I wanted my mom to be in a palliative program and in a hospice program, and I said that our goal was to avoid hospitalization. They're like, "What are you talking about? That's where you get good care. If something's going wrong, you need a hospital." And I beg to differ. With cognitive loss, much care can be given outside of a hospital, and often outside of the hospital is much better care for an individual, depending on the situation. But hospitals will increase confusion. They'll increase infection rates. They increase um, mistakes, procedures that don't need to be happening, procedures that shouldn't have occurred, or testing that sends you off on a wild goose chase. Most things can be dealt with very well at home with more of the support that um, being put into place with the palliative care that the hospital may have provided, but that you can have more in a personalized way. And then the other aspects of palliative care that I think are very important is because we're keeping the person front and center, you're more likely to have gone through advanced care planning. You're more likely to have thought through what are the goals, and um, thought through them in a holistic way, not just medical check boxes of I don't want this and I don't want that, but I do want more support in this area, or I am more of an introvert. I would prefer to have less socialization when I get to a certain phase. Again, very individual, but the other is that there is a focus that's not just on the medical needs. And most people, when they're asked what their needs are, they frequently say they need to express their emotional issues, they need to explore spirituality, and they need some practical financial and legal help. And those three things are not necessarily provided in a medical approach, but are definitely provided in a palliative approach. In palliative medicine, there's also um, there's several aspects of care. So there's the physical aspects of care that we've talked about. If you're in a palliative approach, you're more likely to have some of the things that may not be as focused on in a curative approach, like pain or depression, or full assessments. You get more of the psychological care, so that you're more likely to be referred to therapy or provided some psychological support um, within the palliative care, or or referred to a specialist. The social aspects of care, the um, somebody will be looking at the whole family dynamics and potentially bringing together a family team meeting to help everyone get on the same page, so that there aren't people fighting with each other on the approach to care, or there aren't people feeling left out, or issues like that. There'll be the spiritual aspects that don't necessarily always get taken care of, but as you saw on the slide before, people want something about the existential aspects, the higher level um, needs in Maslow's hierarchy of meaning, to get to some of those more meaningful things, so that we can see if there's aspects of legacy that need to be taken care of. And then finally, some of the ethical and legal aspects, whether there's a healthcare proxy, um, are we honoring those preferences that someone has stated, and not honoring uh, the loudest family member, for example, saying, I can't have it this way. So getting to the point where the person's situation is honored, and not necessarily the loudest person in the room. And here you can see that on a palliative or a hospice team, that the team is large. It includes doctors, nurses, social workers, spiritual counselors, potentially nutritionists, pharmacists to help with the multiple medications that may or may not be needed, allied health, such as physical therapy, occupational therapy, speech therapy. People who are considered part of the team are the person living with the diagnosis and their family, because they are part of that team. And then any legal experts that may be, or financial experts that may be required. And so when you look at this, here's a few examples of how this might be helpful. Um, if is as you're working your way through a disease, medications may be needed and at some point in a disease, but there's another point where they may become more harmful. Um, then they may be causing harm rather than help. And when do you take those away? And how do you counsel everyone around that? And deprescribing is a difficult thing to think about at times, but a hospice team can, or a palliative care team can help you walk through kind of all your questions and answers on that. I mentioned facilitating discussions among families. There's often a lot of reactions around serious illness, around dementia, around the grief and the changes that can come. And people, families have triggers that may be old and aren't helpful as adults. Sibling rivalry that's remained into adulthood, um, resentments that haven't been resolved, and there, I mean, the time of serious illness can bring a lot of that out. And so the social aspects or the psychological aspects can be helped here. The spiritual or existential, again, we talked about making meaning and the importance of love and legacy addressed, and then adapting. And one thing we talk about in almost every program in CaringKind, or anybody who's talking about dementia, we talk about needing to focus on solutions, no matter how odd those solutions may be. I have a, a family that I was working with where um, the wife really wanted to take walks in the woods by herself. That's where she felt grounded. That's where she felt safe. That's where she wanted to think by herself. And her husband was petrified that with her cognitive changes, she would get lost in the woods and that he wouldn't know where to find her. And so their quirky little solution, we talked about it at several meetings, was he would put a bench in the woods for her and that she would have to wear an um, orange cap so that he could see her. So he would watch her from the yard, but she would get to go into the woods and have her quiet time. And so it was a compromise between her need for that independence and that alone time, and that uh, bathing in nature, and his need for, I need to keep an eye on her. I need to be able to find her. I need to watch her. They were actually at a place where there was no cell service, so he wasn't able to track her necessarily. So the orange cap did the trick. That was their funky little response. So how do you get palliative care? Well, you can go to getpalliativecare.org to find places that may support you wherever you may be living. But I want you to remember that palliative care is for any time in the disease trajectory. It could be early stages to help you with some of those decision makings. It could be in the middle stages as you're trying to grapple with what is the right care for this time. And it can be in the late stages when you're thinking about, is it time to bring in hospice or not? It is for the entire family. It is for the whole person, as we've been talking about, and it can be anywhere. It can be at your home. It can be in a skilled nursing facility, and it can be during a hospitalization, and it can be across all those places. And when you're in a palliative care program, you're still allowed to receive curative care if there is, or more aggressive care. When we start to talk about not receiving curative care is when we switch to hospice. And I want to compare palliative care versus hospice care. They are incredibly same or similar. They're the psychology, the physical and psychosocial relief is the same on both. They have the same philosophy. They both focus on quality of life. They both have the multidisciplinary team. Hospice is basically a subset of palliative care, or I like to think of it as a medical benefit under palliative care. I mean, it's both a medical benefit and a philosophy. So I like to think of palliative care as the philosophy and hospice as the medical benefit. That's how I separate the two. Hospice is for a prognosis of 6 months or less, which is not as easy to figure out in dementia, but there are guidelines that can be followed. And palliative care can be given concurrently with curative or aggressive treatment. Hospice, you say no, thank you to that more aggressive treatment. Those are the two of the differences. But hospice care has some advantages over palliative care. As I mentioned, it's a Medicare benefit. Sometimes it's covered by different healthcare policies, but for anyone 65 or older, they're eligible for hospice if their disease reaches a stage that makes them eligible. Not as clear cut in people under 65. The philosophy, as I mentioned, is the same. In hospice, you are to forego curative care, um, but you have to remember that hospice you can go in and out of hospice if you want. If you say, I want to be in hospice and you change your mind, it's okay. Change your mind at any time. You can come out. You can go back in again as well. But it's not, if I go into hospice, I'm always in hospice. That's not necessarily true. And there are huge advantages to invoking hospice at the right time in a disease. It covers end of life medications. It provides the durable medical equipment that may be necessary, such as hospital beds, wheelchairs, commodes. You don't need to buy them. You basically get them via hospice. And the day after you don't need them any longer, they're taken away. So you don't have to worry about, what do I do with this now? It has that full multidisciplinary team. And I think one of the biggest benefits is that you get a 1 year post-death bereavement support for family members. Having gone through supporting somebody living with cognitive loss and then being very invested as a care provider, as a care partner, and then losing my mom, that there was losses that I hadn't even imagined. The loss of my role, the loss of my mother, the loss of the team that helped me support my mom. There was a lot that I needed some a post bereavement support, and I found many other family members who say the same thing. When I'm asked about hospice, there are a lot of myths uh, and untruths that are out there, that are held, and I would like to just, put some of them to rest. Hospice is, some people think, only for the last few days or weeks of life. That is definitely not true. It unfortunately is true that about 16% of people in hospice have a dementia diagnosis. Far too few. The other, what I think of as not a good statistic, is only about 20% of them, of those people who use hospice, are only in hospice for 3 days. So basically, we're calling hospice in far too late. My mom was in hospice for 2 years, and I am so happy that she was. She went into hospice on a day where she developed pneumonia, and I knew that going to the hospital would not be the most advantageous for her. And I wanted her to have support around her breathing, around her symptoms. And so hospice came in and we were able to keep her comfortable and I didn't know if I was going to lose her to that pneumonia. She survived and did very well. And we kept her out of the hospital and she got over her pneumonia very quickly, no delirium, did very well. She went and had another drop off, had another pneumonia, did very well with that one as well. Didn't need the hospital, got the symptom relief that we needed. She didn't bounce back as well from that pneumonia, but I mean, she basically went to eating only ice cream. I could think of worse things. So we kind of dropped away with some of her nutritional support that was a little more aggressive. And she lived on ice cream for quite a bit of time. Again, she went through several medical conditions that could have been she could have been hospitalized for, but she didn't, and she didn't have to go through poking and prodding that she wouldn't have understood. She was supported by the people who loved her, and knew how to care for her, could read um, her nonverbals. She was nonverbal at that time, and she did very well. It's not just for, so that's one myth, is that it's just for the last few days of life. It's not. It's for it's for quality life, as long as you can be out of aggressive care, but that doesn't mean you're out of care. I mean, I believe my mom got very good care. It's not just for the people living with a diagnosis. I would say hospice helped me as much as it helped my mom. I had a nurse at the end of the phone anytime I needed her with any questions I had. I had a, s- a s- a psychologist who um, would supplement. I mean, I chose to get a therapist as well the because of my issues around care partnering and my rigidity as a doctor. And she helped me work through some of that. But it it's for the whole family. It helped my siblings who lived far away, not have to just rely on me, but get information from other people. So they felt like they were getting a full picture of how my mom was doing. Some people think hospice is costly. It is not. It is a Medicare benefit. And finally, that the medications that we use in hospice can hasten death. And statistics show that there are medicines that are used that, if misused, could cause death, but they're not, they're there for symptom relief. And the statistics show that people in hospice actually often live longer than people who are out of hospice. And unfortunately, what we do in this country, so that we think those medicines are causing death, is that we get in there too late when the medicines are needed, because people are already in the stage of active dying. But if hospice is used kind of at the right time, people actually do better and have a better quality of life up until their death. And so finally, in this talk today, we're going to talk about facing the changes that accompany late dementia, so that plans can be made sooner. And I know that this isn't always the most, is not part of talks that people necessarily want to hear. But again, this is part of understanding the disease, understanding what's coming our way, so that we can address it and then get on with the living. So kind of seeing what's down the road, not dwelling on it, but understanding it, so that we can then stay where we want to be most of the time. So recognizing the transitions to late stage dementia is looking at symptoms and indicators. So in the later stages, there is severe cognitive decline, not the forgetfulness that comes with mild cognitive impairment or early to moderate stages of dementia. There is physical immobility, starting to lose the ability to use your hands appropriately, to feed yourself, or to walk effectively. And then frailty, where people start to sleep more, withdraw more. And so the medical signs can start being frequent infections. And part of this is because the signals from the brain to things like the throat to swallow effectively um, stop, so that food may not be getting into the stomach and occasionally getting into the lungs, causing an infection, or the bladder is not squeezing um, as efficiently as it once did, so that urinary tract infections just become much more common. I've been I've been asked by several people, but my sister's not keeping my mother clean. She keeps having urinary tract infections, when it's not that at all. It is that the the signal from the brain is not squeezing the bladder so that the urine is expelled, and that just sets people up for infections. It has nothing to do with cleanliness. It's part of the disease process of dementia. Um, and then the emotional signs, the things of the withdrawal and the difficulty with alertness. I've had several people tell me, but they're not being stimulated enough. They're just sleeping all the time. But some of that decreased engagement and that it can't be fought. They need the rest. They need rest. People need rest between activities. Towards the end of my mom's life, she was sleeping between 18 and 22 hours a day, but the 2 hours she was awake were often very good. I mean, again, she was nonverbal, but much better. Able to engage with me, recognize me off and on towards the end of her life. And there's another way that we can look at when are we in the later stages, and it's called the Functional Assessment Staging Scale. And it bases the staging on function. And so it has stage 1 through 5, which are early in the disease, where there's no difficulty, that nobody, stage 1, you don't, things are normal. You're probably not diagnosed with cognitive loss. Stage 2, where people begin to complain of forgetfulness, where things are located, starting to have some other difficulties with work, for example. Stage 3, where job functions may become evident to coworkers, where you may have difficulty when you travel to new locations, not being familiar with your surroundings, making things more difficult. Stage 4, where executive function, things like planning a dinner for guests or handling finances, start to become uh, impaired. And then stage 5, where there may be difficulty with ch- a little a little more simple executive function, like choosing the right clothing, things like that. And then when we get to stage 6, when we're starting to move into moderate dementia, they start to lay out the this the fast scale a little bit more, so that there's 6A, B, C, D, and E. And 6A would be improperly putting on clothes. So you're starting to lose some of your activities of daily living. You're not necessarily dressing appropriately anymore. You're not bathing appropriately, and that can mean not able to choose the right water temperature, or you may be getting in the shower but not remembering to actually um, wash your hair or scrub things. Uh, th- um, at stage 7C, I mean 6C, it's the inability to handle the mechanics of toileting. You may still be getting to the bathroom, but not necessarily cleaning yourself appropriately afterwards, or flushing the toilet, or appropriately disposing of toilet tissue. And then finally, in the moderate stages, you may having incontinence both of urine and um, fecal matter. And then finally, when we get into the late stage of dementia, and this is where you start to become eligible for something like hospice, we're in the later stages, or what we consider severe dementia, and that's where you're going to start seeing changes in things like talking, where using appropriate words starts to become very limited, down to 6 intelligible words in the course of an average day, or in the course of an extended interview, where speech ability is becoming limited to just a few words, um, or repetition of the same words over and over. Finally, in 7C, the ability to walk um, becomes lost. People start falling, needing assistance of a person to help with walking. 7D, cannot sit up without assistance. 7E, losing the ability to smile. And 7F, having lost the ability to hold the head up. So these are the latest stages. When you're at these stages, at this stage, you would be eligible for hospice if you're also losing weight, sleeping more, um, things things like that. And so I know that what I've talked about so far has been quite a bit, quite a heavy load, actually. And I will just quote T.M. Walker, who is somebody who works in the caregiving field. And she says, caregiving often calls us to lean into love we didn't know possible. And I know that when I was caring with my mom, leaning into love is what made it fun, what made it worthwhile, and reminded me to get out of my doctor head and into my daughter heart, and made me love what I was doing. Um, so in to kind of recap, in preparing for this transition, living with dementia may become a point where we start to die from dementia. And when this happens, we need to remember to shift to a supportive care. And will and that I mean, if I can say, we will ease the care and the dying process. Um, Understanding and being informed about those changes may be difficult. But it's important, and it helps you plan for that. Um, you will likely have more understanding and be ahead of many healthcare providers. And so you most likely will be advocating for yourself or the person that you're supporting in their cognitive loss. Um, and this I can't focus on enough, that you may be given advice that you think, I've already thought through this and this isn't quite right. It's okay. Advocate for yourself or your family member. When you know what to expect from palliative care and hospice care, you're more likely to use it, and you won't be as resistant. And I hope that in the question and answer period, if I haven't convinced you that these approaches are helpful, please ask more questions and I'd be happy to answer them. I do want to say thank you for how amazing you are in your compassionate care and thoughtful decision making. Living with dementia, supporting someone with dementia, not an easy road, but meaningful. And I appreciate you all being here and doing the care that you're doing. If you need someone at CaringKind, if you would like to talk to a navigator or use the helpline, the number is here. Here's my contact information if you'd like to reach out to me as well. And we have our walk coming up in October. If you would like to be part of that, please let us know. If you'd like to have a walk team, that would be great as well.
And again, here's just our contact information. Please feel free to reach out if this conversation raised any questions for you. Particularly, we do have our navigators are available on our website. You can either call or you can fill out the form and schedule a time to book an appointment directly with one of our navigators to have a conversation. But thank you all so much for being here. Thank you, Anne, Dr. Kenny, for your insights and your wisdom and your willingness to share your experience with us all. There was a question about Anne's books. You can get them on Amazon, and she'll sign them for you as well. If you come to the walk, she'll sign them for you. And we do that you'll join us in Central Park. For those of you who are local, we'd love to have you come out. It's a great day on brain health, and we'd love to have you come and enjoy that with your families. Again, I'm Stephanie Shivers, and it is a pleasure to be with you all tonight. Thank you for tuning in, and we'll see you all hopefully again next week.